Hi, everyone. Welcome to our first of the morning workshops for the Brain Injury Alliance annual professional seminar. Hope you were able to all attend the keynote session, and we thank Dr. Corrigan for his wonderful presentation. Before we get started, I want to remind everyone about CEUs. You will receive an email with links to evaluations for the workshops you attended. Completion of these evaluations is a requirement for earning CEUs. And also, please don't forget to visit our website, BIANJ.org, to view the poster presentations. There's some great information there being presented by senior level students in healthcare. I'm Dr. Sue-Ann Chen. I work at Shore Rehab Institute in Brick, New Jersey. I've been on the panel for the planning committee this is my first year, and it's been a delight, and it's really exciting times to be able to present to you in this new format. I am very excited to introduce our next presenter. Dr. Alfonso Thomas is doing a workshop on non-pharmacological management of sleep disturbances after traumatic brain injury. Dr. Thomas works with me at Shore Rehab Institute. We are an affiliate of Hackensack Meridian Health and JFK Johnson Rehab Institute. Dr. Thomas manages and is the director of all of our outpatient care services, including our aftercare program. She completed her physical medicine and rehabilitation residency at New York University Rusk Rehabilitation and completed a brain injury fellowship at JFK Johnson Rehabilitation Institute. She's also an assistant professor in the Department of Physical Medicine and Rehabilitation at the Hackensack Meridian School of Medicine. She currently manages patients requiring neurorehabilitation, such as stroke and TBI, at our Shore Rehab Institute in Brick, New Jersey. Please join me in welcoming Dr. Thomas.
Thank you, Dr. Chen, for that introduction. Share screen. Okay, once again, thank you, Dr. Chen, for that introduction. So our morning session today is on the non-pharmacological management of sleep in traumatic brain injury. A lot of the information that I'll be talking about today is taken from the literature review and publication that I have with Dr. Brian Greenwald in the Neurorehabilitation magazine. Some of the objectives that I want to achieve with you guys this morning is to be able to discuss the importance of sleep in TBI, to briefly review sleep anatomy and how to diagnose sleep disorders, and to get into the meat of our talk, which is to discuss the different conservative measures available to help patients with sleep impairments. So sleep disorders can be found in patients with all severities of brain injuries from mild to severe, and it's a relatively complex process that involves many parts of the brain. Now, depending on the location and extent of the injury, you can find many different types of sleep disturbances that can occur as well. So it's a relatively large prevalence. Sleep disorders in TBI ranges from 30 to 84%. And it's estimated that about 68% of patients in rehabilitation units demonstrate some form of sleep disturbance. It can happen as soon as 24 hours after an injury and can last several years as well. Some of the most common sleep disturbances found in the literature have been insomnia, which can be a difficulty falling asleep or sleeping through the night, poor sleep maintenance and sleep efficiency, which falls under circadian rhythm disturbances. These patients may typically complain of difficulty falling asleep at usual bedtimes or difficulty getting up at normal wake times, early morning awakenings, excessive daytime sleepiness, which can be seen as an inability to maintain wakefulness during major waking hours or sleeping unintentionally, nightmares, and some breathing disorders as well, such as apnea or narcolepsy. This is just a fun resource for TBI patients on sleep that I found on the University of Washington TBI model systems. It goes through the importance of sleep in TBI, how it can be affected after brain injury, and how poor sleep overall can lead to poor performance and recovery. Just a brief look at the sleep cycle. There's 5 stages. Stages 1 through 4 compromise what we call non-REM or non-rapid eye movement sleep. As you progress through stages 1 through 4, the sleep becomes more and more deeper. And stages 3 and 4 are considered to be the more restorative or relaxing form of sleep. Stage 5 is what is known as REM sleep, rapid eye movement sleep, which is often associated with dreaming. Now, the sleep cycle in TBI patients, studies show that TBI patients were found to spend less time in REM sleep and also had a longer REM latency. So pathophysiology of sleep disturbance in TBI. So when you look at sleep disturbances, you want to look at direct and indirect causes. Direct injury to sleep centers can be a major culprit. And as I mentioned before, sleep involves several areas of the brain. Specifically, we're looking at the hypothalamus, the brainstem, the pineal gland, which we're familiar with, releases melatonin. And these areas contain specific nuclei which release certain neuropeptides or neurotransmitters which are involved in sleep. And it's the disruption of these systems that lead to the different sleep disturbances that we see. So TBI groups, studies have shown that have decreased levels of orexin, histamine, serotonin, and melatonin in the CSF. And looking at orexin and histamine, which are specifically weight-promoting neurotransmitters, low CSF levels were found to be associated with hypersomnia or sleeping too much. In a study of 44 patients in the first several days after a moderate to severe TBI, levels of orexin were found to be decreased in the CSF of 95% of the patients. Reduced melatonin is also associated with decreased REM sleep as well. Now, looking at some of the indirect factors, you want to take a look at things such as medications, psychiatric conditions, which I'll go into more information on our next slide. So with diagnosis, history is a key component. You want to look at several factors, starting off with environmental factors. You want to make sure the environment that you are in, the patient is in, is conducive to sleep, meaning a restful atmosphere, no distractions, noise, light, or extreme temperatures. Medical comorbidities. Does the patient have diagnoses such as sleep apnea or restless leg syndrome that can keep them awake? You want to review the patient's medication list with them. Are there any medications that may be interfering or stimulating? I've actually had an outpatient that I've seen in the past. Typically, Ritalin is a common drug prescribed in our brain injury population, and I often prescribe it at 8 a.m. and 12 p.m. When reviewing the medication list with the patient, they actually were taking it at 8 a.m. and later on in the evening after 2 o'clock. So it's discrepancies like that that can cause sleep disorders that we can actually correct without any other therapeutic intervention involved. You want to look at a patient's typical routine prior to bed. Are they watching TV or on the phone? Mood, are there any issues with anxiety or depression? And diet. You want to avoid eating before bed, no caffeine, nicotine, or alcohol intake. Sleep diaries are a helpful resource. It's a record of an individual's sleeping and waking times with related information such as a patient's stress level, exercise, naps, and how rested someone feels after they wake up from sleep. A wrist actigraph is something that's been used more and more commonly now. It's a sensor worn typically on the wrist, which measures rest and activity periods by detecting motion. A multiple sleep latency test uses EEG to measure and quantify excessive daytime sleepiness. And polysomnography, which is sometimes considered gold standard, is an in-lab diagnostic tool that monitors many body functions and a comprehensive recording of a patient's biophysiological changes. And it includes EEG, monitors eye movements, muscle activity, heart rhythms, and breathing patterns as well. So consequences of poor sleep in TBI. So sleep is important for all individuals, and the lack of it can lead to several consequences. Me talking from personal experience myself, I currently have a 4-month-old at home who's going through what you can call a sleep regression and likes to wake up every hour. So I kind of have firsthand experience of how sleep can cause impairments in mood, attention, concentration, memory, and learning. In our TBI population, poor sleep can lead to poor neuro recovery, longer hospital stays, which leads to higher costs of rehabilitation and higher rates of functional disability. So getting into treatment. So how can we help our patients with TBI regulate their sleep cycles and attain restful sleep? So given that sleep disorders can appear early after TBI and that it can lead to poor clinical outcomes, it's beneficial to consider therapies early on in the recovery process. There are several options for sleep management, and a lot of the therapies listed are extrapolated from data used from non-TBI patients with sleep disturbances, but also from smaller studies with TBI patients as well. Patients and practitioners need to be aware of all of their options for treatment. And first and foremost, again, you want to treat any underlying conditions that may be leading to patient complaints of excessive daytime sleepiness or fatigue, going back to mood, any untreated disorders such as sleep, obstructive sleep apnea. And here on this slide, I specifically have mentioned some non-pharmacological options that are mentioned in the literature. And one of the main benefits of using non-pharm treatment over medications is that you're limiting the risk of any side effects or drug-drug interactions. And a conservative approach is something that all practitioners and treaters should use as basis for treatment before moving on to any of the bigger guns, you can say, such as prescription medications or surgical or other non-over-the-counter treatment before, treating their patients. So sleep hygiene and behavioral therapy. It's something that should be used in all patients with sleep disorders, given that it's relatively low cost and low risk. Sleep hygiene comes with specific domains. You want to look at sleep homeostatic factors. Sleep homeostasis, the body is always maintaining a balance between sleep and waking. Exercise is an example of a homeostatic factor. It helps to build up the sleep drive, your exhausting energy, and can lead to a more restful sleep at night. We look at circadian factors, regulating your day and night cycles, medication drug effects, and arousal during the day in regards to sleep. Cognitive behavioral therapy is something that's been studied with the TBI population specifically. Its primary goal is to alter patients' negative associations with sleep. Some of the techniques used, you have stimulus control, where you want to look at the patient's sleep habits and pinpoint different actions that may be prohibiting sleep. Sleep restriction, limiting time in bed for strictly sleep only, and relaxation techniques. The use of these approaches were found to actually improve sleep onset and efficacy while decreasing nighttime awakenings in TBI patients. Again, another fun info comic on sleep, looking at behavioral and environmental changes. I don't know if you guys can see it clearly, but you want to remove any distractions, have a bedtime routine, avoid drinking alcohol, try to do meaningful things during the day, get fresh air and light, try to avoid caffeine intake. And it's pretty much altering these habits that help promote sleep, but also set someone up, specifically our TBI patients, for a better mood and cognitive capabilities as well. A table kind of emphasizing again the components of cognitive behavioral therapy: stimulus control, associating the bed and bedroom with sleep, sleep restriction, sleep or time spent in the bed or bedroom only for sleep, cognitive therapy for insomnia, identifying any negative attitudes or beliefs, sleep hygiene, which we went through, kind of reinforcing a conducive environment for sleep, fatigue management, which is primarily education to increase awareness of fatigue, how to manage it, and how to conserve energy at the same time. So light therapy is another option that's been studied in the brain injury population. It's found that ocular light exposure of certain wavelengths has been used as a stimulant and antidepressant. It's known to stimulate circadian, neuroendocrine, and neurobehavioral responses. Blue light specifically has been shown to improve sleep efficiency, sleep time, and reduce nocturnal awakenings. A study in the TBI population had patients receive 4 weeks of blue therapy for about 45 minutes a day at home. And what the results showed was that it helped reduce fatigue and daytime sleepiness. The same study also went on to report that the magnitude of reduction in the light therapy group was comparable to a study which used modafinil daily for 6 weeks. And modafinil, as some of you all may know, is a common drug that we use to promote wakefulness in our TBI population. Chiropractic and osteopathic manipulative treatments. Limited studies on this. We'll start off by talking about chiropractic treatments. Research suggests that spinal manipulative therapy excites GABAergic inhibitory neurons, which therefore promotes relaxation of the mind and non-REM sleep. That's a chiropractic aspect of it. I couldn't find much on the brain injury population, but looking now towards osteopathic manipulative treatment, there are a few studies looking specifically more in the concussion population. OMT, or osteopathic manipulative treatment, involves visceral and neural manipulation, targeting restriction in the tissues, bones, and organs and nerves of the body. As a DO myself, a lot of my training in med school had this as a basis in treating patients, looking at the body as a whole and what you can do to treat the patient as a whole and try to avoid medications if we can, and use our hands as a treatment modality. Besides the visceral neural manipulation, craniosacral therapy is a form of non-invasive therapy aimed at correcting any restrictions within the craniosacral system. Now, what is the craniosacral system? It's comprised of the cranial bones, sacrum, meninges, and CSF. And the primary goal of the treatment is you want to promote free and fluid movement of these structures, and that's where you attain the therapeutic effects of the treatment. A study by Wetzler et al. Used different OMT techniques and studies its effect on concussion recovery. And what the results showed that therapy significantly reduced pain around the head and neck area and increased sleep time as well. And the study also went on to report that treatment helped reduce fatigue and anxiety in the concussion population that they studied. Going a little bit deeper into craniosacral therapy, the basis of the therapy looks at the primary respiratory mechanism, which manifests as a motion of the cranial bones, sacrum, dural membranes, and cerebrospinal fluid. And the primary respiratory mechanism can be palpated by a well-trained osteopath. As we all inhale and exhale, there are subtle movements that can be felt from the cranial bones, movements such as a subtle flexion or extension and internal and external rotation. And primarily, you see it in the picture right here, it's the occiput and the sphenoid bone that's typically palpated with craniosacral therapy. And it's a disruption of the free fluid movement of the system, such as when the bones are rotated improperly or stuck in a certain position, that causes these issues with sleep, and therefore correcting it can lead to better sleep as well. So with treatment, you involve the gentle application of manual force to address somatic and dysfunctions of the head. And specifically, certain techniques can be used to reduce sleep latency by decreasing sympathetic tone as well. Acupuncture. A pilot study that I found on TBI patients with chronic insomnia found that those treated with acupuncture were able to taper off sleep aid medications within the first week of treatment. The data did not reach statistical significance, but it is notable. No difference was found in total sleep time, but those with acupuncture reported a higher quality of sleep, and the effect was noted to last at least 1 month after discontinuing treatment. I've had some firsthand experience with acupuncture myself. I was certified in New York during my residency and treated several patients. The basis behind acupuncture is unblocking a blocked channel of energy or qi within the body, but also lends itself to some musculoskeletal treatment as well, such as release of tight muscles or tension around the head and neck area. There are specific insomnia points, you can say, and also several points to help promote relaxation and a sense of calm in the patients who are treated. Diet. So dietary therapy looks into providing the body with the building blocks it needs for the different deficient neuropeptides or transmitters that are specifically lacking after a traumatic brain injury. The goal of dietary therapy, again, to modulate neurotransmitter activity. That's specifically associated with the sleep-wake cycle. Some of those neurotransmitters are orexin, serotonin, glutamate, and GABA. And the dietary changes help to supplement, again, the brain with the building blocks it needs. Orexin specifically, like I mentioned before, helps to maintain wakefulness. And we look into orexin with branch chain amino acid dietary supplementation. The BCAA is a precursor to glutamate and GABA synthesis within the brain, and they both act as mediators of orexin neuronal activity. Studies show that TBI decreases the density of glutamate within presynaptic nerve terminals, who make an excitatory synapse onto orexin neurons. So therefore, supplementation of this kind of restores orexin neuronal activity. Studies show that BCAA supplementation into mice with TBI has shown restoration of sleep-wake cycles and orexin neuronal activity. Another dietary supplement is L-tryptophan, which is a precursor amino acid for 5-HT or serotonin. And here you kind of supplement the body with that using a carbohydrate diet. And what this does is it increases the available brain tryptophan via promoting insulin, which pushes large neutral amino acids into skeletal muscle. These large neutral amino acids actually compete with tryptophan for entrance across the blood-brain barrier. So increasing your insulin is what helps make tryptophan more available to be used to help create more serotonin. A high carbohydrate diet has been found to increase REM sleep, decrease light sleep, and promote wakefulness. Serotonin is also a precursor for melatonin. So actually increasing the available tryptophan helps boost melatonin levels as well indirectly. So speaking of melatonin, it's a hormone secreted from the pineal gland, and it helps to regulate sleep-wake cycles following a circadian pattern of release into the bloodstream. Hormone is typically low during daylight hours and subsequently increases during the day as the body is exposed to less and less light. TBI patients tend to have lower melatonin levels than their healthy counterparts. A study by Grima et al. Showed that 42% less melatonin overnight was found in the TBI group compared to controls. And the patients in the study actually averaged 6 years post-injury, which suggested that the disturbance in the melatonin pathway is an ongoing impairment. Supplementation with melatonin is commonly used, has been shown to improve subjective sleep quality and actigraphic sleep efficiency. And melatonin actually reduced self-reported anxiety, fatigue, improved self-perceived vitality, and mental functioning as well. So research into herbs and other nutritional remedies are relatively scarce. I did find that valerian is commonly used in the non-TBI population. It's an herb. The dosage varies from 300 to 600 milligrams a day. And the thought process behind valerian is that it's thought to induce a calming effect by binding to GABA A receptors and attenuating the excitability of the nervous system. It's effective for subjective improvement of insomnia. Now, the thing with valerian is that it is not FDA regulated, so preparation content and concentration can vary. Other nutritional remedies that are commonly found in over-the-counter sleep aids are hops, passion flower, kava, lavender, skullcap. Several options are available, but none that I found specifically studied in the brain injury population, but it is something that can be worth trying, but with close monitoring as well. Studies have shown that mindfulness meditation has led to reductions in sleep pre-arousal time. Give me 1 second here. Go back. Okay, here we go. Mindfulness meditation. So it's shown reductions in pre-sleep arousal time and insomnia severity index. Evidence that regions of the brain, such as the insula, putamen, somatosensory cortex, were found to be activated with mindfulness meditation. Studies found that activity within the amygdala can be adjusted, which helped to reduce anxiety and depression, and that routine meditation appears to lead to improved emotional control and regulation. There was a study specifically in the TBI population using home-based foot baths. It found that these foot baths reduced latency of sleep and waking after sleep onset. And the proposed mechanism was modulating the firing rate of warm sensitive neurons in the anterior hypothalamus. Apparently these neurons are postulated to increase their firing rate with the initiation of sleep. So therefore the study found that increasing skin temperatures led to a similar rise in the firing rate of these neurons leading to sleep. Cranial electrotherapy stimulation. So the research on use of this in TBI was lacking, but it is an FDA-approved treatment method to decrease insomnia in non-TBI patients. It involves the use of a small electronic device that sends weak pulsed electrical stimulation to the brain via electrodes on the scalp. And neurophysiological effects that were noted was an overall relaxation due to the release of neurotransmitters such as beta endorphins and other hormones and neurotransmitters. Functional magnetic resonance imaging found that the use of cranial electrotherapy stimulation caused some cortical deactivation. So marijuana is often a popular topic, and mixed results in literature. Some anecdotal stories from my patients as well, some who have tried it which found benefits, some who have tried it and really didn't work out for them. But tetrahydrocannabinol, or THC, suggests that it provides a short-term sleep benefit, but that chronic use can lead to habituation and a less pronounced circadian rhythm, daytime sleepiness, delayed onset sleep latency, negative mood, and memory impairments. Cannabidiol, or CBD, has a lower addiction profile compared to THC, and at low doses, it has been shown to be stimulating, while at higher doses can be sedative. Noted effects on sleep disorders include an increase in total sleep time. You want to take some caution with the TBI population, as use of marijuana can lead to a worsening of cognition, and can be hallucinogenic as well. So definitely more research is needed in this area. So sleep is a very important thing for all humans and for our animals. Proper sleep helps with neurorecovery. Failure to obtain adequate rest has been associated with impaired cognition and physical function. Using conservative measures prior to the institution of pharmacological agents has been shown to help prevent the unwanted side effects of medications. Several options exist for non-pharmacological management of sleep in the TBI population, some of which we spoke about today. And overall research is limited, and there's more areas for research to be done to help specifically tailor treatments to our brain injured patients. Some of the references that I used here. And I want to thank you all for attending. So I want to open it up for questions so we have time to answer questions.
Okay, the question and answer session will now begin. I will be reading the questions from the attendees and relaying them to Dr. Thomas. The first question is, have you seen any legitimate research on the blue light glasses? Would this help people with brain injury wind down and possibly improve sleep habits, especially when streaming shows or on the computer at night?
Okay. So I haven't found any legitimate research specifically, but the blue light glasses are something that I incorporate with my concussion patients, specifically when they are using, like you said, the computer or on their phone, just to decrease headaches. So the thought process behind that, by decreasing headaches, you're kind of creating a more restful environment, a more peaceful state of mind and body. So it is something that can be considered to improve sleep habits for sure.
Thank you. Next question. Are there any concerns when using melatonin, like a decrease of its effects building of tolerance after prolonged use?
There are concerns. No studies I can mention off the top of my head, but as with any drug, your body can develop a tolerance to it. I use melatonin very frequently in all of my brain injured population, specifically given studies have shown that melatonin helps with not only just sleep, but with headaches as well. So I take it as a case-by-case basis. If a patient continues to show benefit with melatonin, I obviously keep them on it. Over time, I do try to wean patients down of the medication and see how they do. If they do well off of it, then of course I stop the medication. Otherwise, I do continue it. I tend to go up to 10 milligrams on melatonin when I do use it.
Thank you. Next question. How does a person qualify for craniosacral therapy? Are there specific symptoms?
So craniosacral therapy, it can be used on a good majority of patients. Those patients I would be wary of would probably be patients who have had seizures or our seizures are not controlled. Specific symptoms for patients who may qualify for it can be headaches. Like I mentioned, the torsion and the rotations of the bones of the head it may not necessarily be something you see just by looking at a patient. You need to get them lying down, get your hands on them. So anyone can qualify. You just want to make sure there's no risks that overshadow the benefits. Specific symptoms that may qualify for craniosacral therapy: headaches, sleep disorders. I use craniosacral therapy for sometimes, cognitive complaints as well, visual complaints. So there's a whole slew of things craniosacral therapy can be used for.
Okay. I work with an individual that attributes sleep difficulties to hearing sensitivity. Is this something you've come in contact with?
Sorry, Joy, can you repeat that question again?
I work with an individual that attributes sleep difficulties to hearing sensitivity. Is this something you've come in contact with?
I haven't come in contact with it, but I don't deny that that is possible. Poor sleep kind of can make your body sensitive to the numerous stimuli around you, loud noises, loud lights. So having your hearing slightly be more sensitive is definitely something that would be in that area.
So the next part, do you think this person might be confusing the hearing sensitivity for chemical imbalances? And what sort of physician service provider would be appropriate to explore and address something like this?
Sorry, Joy, you cut out again.
Do you think this person might be confusing the hearing sensitivity for chemical imbalances?
I'm not sure what you mean by chemical imbalances.
there might be something organic going on
Okay.
as opposed to hearing sensitivity.
I'm not sure. I would probably start off with just getting a history from the patient and then just making sure from an audiological, make sure their hearing has been tested, and then ruling out any medications that might be affecting their hearing as well. Kind of take it as a step-by-step, take a treatment protocol to it.
Thank you. Has there been any research on weighted blankets to help individuals that have sustained a brain injury to sleep better?
No research that I'm aware of. I know it's commonly advertised that weighted blankets have helped individuals with non-brain injury help sleep better. So it is something to consider with treatment.
Okay, thank you. How do you see impaired vision and headaches contributing to impaired sleep in your experience?
So not sure about the impaired vision part, but the headaches definitely can keep someone awake at night. Impaired vision, it may lend to sleep homeostatic factors. This is me talking, kind of pulling information from what I've read and seen. Pain management, tension around the head, the neck, can all interfere with proper positioning at sleep and just overall restfulness.
Thank you. Another question is about sleep restrictions within the cognitive behavioral therapy method. How do sleep restrictions work? When patients are recommended to leave their beds when having restless or not sleeping, what activities should they be doing to relax the mind so they may return to bed?
So anything that would not be seen. So like I mentioned, you want to avoid TV or the phone. They can go for a quiet walk around the house or reading a book, things like that. Things that the patient might find restful. Obviously, you want to discuss with the patient what they find restful, but reading a book or going for a walk, sitting quietly, meditating, using aromatherapy, just doing deep breathing, all can be done to help relax the mind and body.
Thank you. Next question. Are there any specific websites or books we can use for mindfulness meditation?
I know there's going to be several. So if you want, you can email me. I can give you a few resources.
Excellent. Thank you. In regards to medical marijuana, are there specific requirements patients must meet before being prescribed this treatment approach?
So I don't prescribe medical marijuana in my office, but I do refer out to those who do. Specific requirements that patients must meet. If you're talking for a TBI patient in particular, I would just make sure it's a patient who would be compliant in terms of using it as prescribed and who can be reliable in terms of, being truthful with you in terms of how much they're using, but no specific criteria that I've come across.
Thank you. Which provider would best be able to prescribe different supplements such as glutamine, BCAA, and the high carb diet? Also, are there different groups that might not benefit from high carb diets?
So finding a good nutritionist is definitely key. Also, practitioners who work with who work in integrative medicine have also been helpful in this area with dietary management. Different groups that might not benefit from high carb diets. The first one that comes to mind is typically I worry about our diabetic patients, just to make sure their glycemic control doesn't go overboard.
Excellent.
And my email address is on the last slide of the page.
Thank you. I'd like to thank Dr. Thomas for an excellent talk today. This concludes our workshop. I would ask that you please complete your evaluations